Good afternoon and welcome to the Montana State University College of Nursing Center for Interdisciplinary Health Workforce Studies Fall Webinar Series focusing on the integration of oral and behavioral health services into primary care. We are pleased to have you joining us for today's webinar. My name is Christy Friedman. I am the Program Manager for the Center. A couple of announcements before we begin today's webinar. In new research out in the Journal of Nursing Regulation, Center researchers Peter Bierhaus, Lucy Skinner, David Auerbach, and Douglas Steger examined 4 challenges facing the nursing workforce of today and tomorrow: the aging of the baby boom generation, the shortage and uneven distribution of physicians, the accelerating rate of registered nurse retirements, and the uncertainty of healthcare reform. This article describes these major trends and examines their implications for nursing and how nurses can meet these in a complex and interregulated challenges and continue to thrive in an ever-changing environment. Read more on our website, healthworkforcestudies.com. Second, Health Affairs recently published an article by the Center researchers examining dramatic growth of millennials in the nursing workforce. As we have heard, baby boom registered nurses, the largest segment of the RN workforce from 1981 to 2012, are now retiring. This would have led to nursing shortages, but for the surprising embrace of the profession by millennials, who are entering the nursing workforce at nearly double the rate of the boomers. You can read more on our website or in the October edition of Health Affairs. Third, we've just released second quarter 2017 RN employment data that details key findings, including strong growth in employment of registered nurses in both hospital and non-hospital settings, sharp jump in employment among younger aged RNs, and you can find more of this information on our website and figures for this data. Finally, this past summer, the Center partnered with the National Forum of State Nursing Workforce Centers to conduct a 3-day national conference titled The Nursing Workforce and Health Reform: Trends and Opportunities in a New Political Era in Denver, Colorado. Visit our website for a brief recap of that conference. And again, you can find all of that information and more at healthworkforcestudies.com. After today's presentation concludes, we will have 15 to 20 minutes for discussion and Q&A. Please feel free to type any questions you have in the area designated for questions on your menu bar, and we will get to as many of your questions as we can. Please try to be very descriptive with your questions as well. That will help us get them answered as best as we can. We're also recording the webinar today, and we'll have it posted to our website. We have posted all of previous webinars to our website as well if you missed any of them. You can also find presentation slides for many of the webinars posted within the Video Library tab on the Center's website as well. Excuse me. Now I'd like to turn the microphone over to Peter Bierhaus, Center Director, to introduce our speakers. Pete?
Hey, Christy, it's good to hear your voice again. Well, welcome, everyone. I'm broadcasting live from Bozeman, Montana, where overnight we had some light snow, and the mountains have about a foot or two of snow, and the bears are very busy foraging to put on as many calories for their upcoming hibernation. But I guess we'll get back to the webinar, and my job is to introduce our 2 presenters today, and that includes Hannah Maxey. Hannah is an assistant professor and the Director of Health Workforce Studies at Indiana University School of Medicine. And she's actively involved in health workforce policy research at both the state and national levels. So Hannah has examined the effects of state regulation of the dental hygiene workforce. She herself is a dental hygienist. She's looked at access to dental health care and the oral health status of patients at federally qualified health centers. Hannah has also led or been involved in multiple health workforce evaluation projects, again, nationally and longitudinal evaluation of the National Health Service Corps program in Indiana, and she served on the 2013 Indiana Dental Hygiene Workforce Task Force. So we're excited that Hannah has joined us. She's had much more in her career than I've had time to talk about. But let me just also quickly introduce Connor Norwood, who will be working with Anna this afternoon. And Connor is a research associate in the Department of Family Medicine at Indiana University School of Medicine. and he serves as the Assistant Director of the Bowen Center for Health Workforce Research and Policy. Dr. Norwood has been conducting health workforce and health policy research that impacts access to care and improves population health. His primary areas of interest include health workforce research and policy, health services research, a lot on oral health and drug abuse. Now, again, could say a lot more about Connor and Hannah, but let's put them on the microphone and hear it directly from them. So I'm going to turn the microphone over to Hannah, and Hannah, take it away.
Thank you so much for that introduction, Peter and Christy, and thank you for this opportunity to share a little bit about some of the work we're doing in the space of oral health and integration into primary care. So the webinar today is titled Delivering Oral Health Care Services. It's not just for dentists. And I would like to start that discussion kind of providing context and framing our discussion around integration and the two papers we're going to share on, and discuss a little bit about oral health and medical care and why we need integration or the case for integration. So you'll notice the picture is a fragmented, artistic human form. And I selected this because it actually exemplifies the way in which oral health has really been segmented from or separated from the overall medical care system. As medical and medicine evolved, dentistry evolved separately in its education structures and policy and formation, and then subsequently within the healthcare system. We currently have a separate subsystem of our larger healthcare and medical care system that is focused on the service as dental service delivery. And unfortunately, because we have this separation, even beginning in the training of our physicians and dentists, that they are trained separately in separate facilities, this separation really has caused a culture, or created and fostered a culture in healthcare that, although many of us are on the same page with that our oral health is part of our overall health, unfortunately, the culture just isn't there that oral health is a part of overall patient care. So where has that left us? Well, quite honestly, in the United States, there are high burdens of untreated dental disease among children and adult populations. Dental diseases such as dental caries are some of the most preventable diseases that we have that are affecting our population. So how are we going to look at our system and our workforce in new ways and try to address the burden of oral health in America? So this has been recognized as a strategic issue for many years. Of course, anyone who's familiar with oral health will recall the Surgeon General's first report on oral health in America that really framed the discussion of oral health disparities and what was going on, kind of the hidden secret of dental disease and poor oral health in America. But after that initial report, there have been a number of federal reports. I said calls to action, although they're not all called call to action, that have come out of the Surgeon General's office and the Institute of Medicine. Each of these reports had different focus areas, but consistently, oral health being integral to overall health was a common theme throughout. And all of these reports, to some extent, called for interdisciplinary, multidisciplinary teams working in settings across the healthcare system to become engaged in oral health care delivery and improving population oral health. It's specifically targeting initially, of course, vulnerable populations, those that are most affected by the burden of poor oral health and dental diseases. These reports also from the Institute of Medicine in 2011 called for core competencies, core clinical competencies in oral health for non-dental healthcare professionals. And you may recall that I mentioned that oral health largely is not covered in medical training, and it has not historically been a significant part of that, primarily oral health was within the realm, the training, the focus area of dentists. So in response to these federal reports that were put out by the Institute of Medicine, HRSA brought a number of key stakeholders to the table to develop what is actually called a formal document, is Integration of Oral Health in Primary Care Practice. This document actually laid out 5 core clinical competencies that are considered required or needed in order for primary care providers or primary care practices to successfully integrate oral health into their practice. And so those 5 areas include risk assessment, oral health evaluations, preventive intervention, communication education, and interprofessional collaborative practice. So where are we at now? Obviously, we have a lot of awareness now. There's federal initiatives. Non-federal agencies at the national level have taken up the charge for working on oral health disparities and integration. And so that brings us to kind of a place where the health system and dental care delivery is looking at ways to integrate oral health into primary care. And it brings us to the point of the papers that we're going to be discussing today. One of the papers, actually both to some extent, focus on integration of oral health within health centers. And so before we go into these discussions, I did want to just share with those that are on the webinar today, kind of why health centers and why integration. Well, health centers are strategically positioned for integration. First of all, they actually have, under their requirement, if they receive funding from the U.S. Health Center program, a requirement to deliver preventive dental services or ensure access to care. So I apologize, not to deliver, but to ensure access to preventive dental services for the populations they serve. And on this screen, there's a lot of text. I don't want to go into it fully, but it's there for your reference if you'd like to follow up. And in the specific code for the U.S. Health Center program, it explicitly states those services that are considered preventive dental services that health centers that receive this funding need to ensure that their patients have access to. And so you'll see those are the preventive services. Patient oral hygiene education or instruction, prophylaxis, which is dental cleaning, topical application of fluoride, so those fluoride treatments that you may receive when you go to the dentist. And so these health centers have a requirement to do that. And not only do they have a requirement, but health centers are the largest network of organizations across the United States that actually co-locate medical and dental services in many of their facilities. So these organizations, as healthcare organizations, are strategically positioned to develop, test, and implement different models for integrating oral health into primary care. And this has been a priority of the health center community here in the United States. I had the great privilege of working with the National Association for Community Health Centers on a monograph project. And the link to that document is available on these slides. I would welcome you to go look at it. But the purpose of this monograph, this document, was to collect and report data on various ways in which health centers had successfully integrated oral health into primary care. And it used those IOH PCP competencies as a framework to look at how integration had occurred. Well, that monograph kind of led to a line of inquiry into what's going on with integrating oral health in primary care. And so our team here at Indiana University at the Bowen Center for Health Workforce Research and Policy has worked on a number of follow-up studies from the monograph. And the 2 papers that we're going to be presenting on today are actually developed as a result of the findings and the discussion that came out of the work on the monograph. So the first of those studies, Dr. Connor Norwood is going to be discussing, and it looked at health center executive leadership perspectives on integration. And the second that I'll be doing an overview on is primary care physician roles in oral health, and specifically at health centers. So I'm going to go ahead and turn it over to Dr. Connor Norwood to talk about the first study.
Thank you very much, Hannah, and thank you, Christy and Peter, for having me today. The first study that we did, the 2 studies that Hannah just introduced, the first was called Administrative Challenges to the Integration of Oral Health with Primary Care. This was published in the Journal of Ambulatory Care Management last year and came about mainly as Hannah said, because of follow-up work from the monograph that was published with the National Association of Community Health Centers. And we really wanted to understand the executive or leadership perspective in FQHCs and understand the barriers or obstacles to implementation of various types of oral health integration models. So just to reiterate, Hannah briefly mentioned the role of FQHCs in ensuring access to oral health services. And I just want to reiterate that in Section 330 of the Public Health Service Act, there is a requirement that FQHCs or federally qualified health centers ensure access to comprehensive primary care, which includes preventive oral health services. And in fact, FQHCs make up the largest component of the dental safety net, and so they are critical in improving access to those preventive health services, such as prophylaxis or various types of screenings. Through the years, FQHCs and various other types of clinics have tried various programs or ways to, quote, ensure access. Some FQHCs have adopted programs where they've co-located dental services or dental clinics within their FQHC. Others have referral programs where they refer patients or link patients to community dentists. Many times that includes a voucher program, or they'll provide vouchers to the patients themselves, and they receive those services for free at discounted prices with those community dentists. Although there is little research on the effectiveness of those voucher programs, and there is some studies out there that question or tell us a lot about the referral rates and to what extent those patients are actually following up. And so what we're really trying to do across the country is figure out how we can develop or implement integration programs that ensure or increase the likelihood that these patients are actually receiving those services and not just being referred to dentists. So integration of oral health and primary care may improve the reach of FQH dental services. Like I said just a second ago, we want to make sure that we're not just referring these patients out to dentists, but that we're actually connecting them with the oral health services. And many times that needs to happen right there within the clinic, or we need to figure out ways to overcome barriers that are many times associated with the socioeconomic factors or status of these patients that are typically served in the dental safety net or the safety net in FQHCs. The mission of FQHCs really embodies that need to improve access to comprehensive primary care, as I said before, which includes preventive oral health services. And once again, the primary purpose of this study specifically was to understand how FQHC executives, including CFOs and CEOs, as well as dental directors, how they perceived the strengths and barriers, strengths and weaknesses or barriers to implementation of various types or structures of integration programs into their facilities. So what we did, we actually did this in collaboration with the Indiana Primary Healthcare Association in one of their annual dental forums, and we conducted focus groups, 3 different focus groups, to collect data to allow us to do a SWOT analysis, or a strengths, weaknesses, opportunities, and threat analysis, to really understand their perspective and identify ways that we may be able to, at the local, state, and national levels, assist FQHCs or these organizations in implementation of these various programs. So we had 29 participants total. We divided them into 3 different groups, 3 different focus groups. We randomly assigned them, but we tried to randomly assign them by the type of title so that we had equal representation of the various titles or positions, including the CEO or the executive director perspective, the chief operating officer or the administration operations side, the CFO or finance managers, and then the dental directors or clinical affairs medical directors perspective. We also wanted to demonstrate who these individuals represent and how many clinical sites were represented by these 29 individual people. Just to point out, this study was not developed as a qualitative research study from the get-go, but it was meant to there was very important information that came about from these focus groups that we felt needed to be put out there and allow other states and organizations to see what FQHCs in our state are saying, so that we can continue to build off that and develop more robust research studies. But those 29 individuals represented 118 different clinics across the state. And on the right, you can see the breakdown of what types of clinics, where they were located, and the specific settings for the representation. We recorded the audio from the focus groups, and we transcribed them, and then we performed a thematic content analysis to identify the major themes or issues that were discussed by these FQHC executives. And at the end, you'll see a link here to the study where you'll be able to get more information about the methods and how it was specifically done. But I want to go right into the results and discuss those 4 themes that emerged. The first was the culture of the healthcare organization and the US health system. So I'm going to read a quote actually from one of the executives, and it said, "I think oral health integration also takes complete culture change because for whatever reason, dental seems to be so separate." And this theme continued to emerge over and over again in all 3 focus groups. And one strength that people identified was that FQHC's culture is that passion to serve, or the commitment to underserved communities. And because there's that passion there, that there's a want and a desire to improve access to oral health and integrate oral health into a comprehensive primary healthcare system. Although they did mention under this culture that the major weakness seems to be patients at FQHCs lack awareness of the importance of oral health care. And because of that, it's difficult many times to get the patients to follow up on referrals or see the need to have oral health services or prevention services for oral health. One of the major threats that the group felt in terms of the culture was that patients and providers needed additional education, and because of the lack of education, they were going to struggle to be able to adopt any type of oral health integration model into their system. The second major theme was the operations and administration of oral healthcare services. So really what they were talking about here was that there had to be an adequate infrastructure to ensure that operations are efficient and cost effective. So delivering preventive dental care requires a different set of equipment within facilities, and there has to be some sort of investment in infrastructure and capital investment to be able to do that, and then there has to be a way to make that cost effective to be able to make it sustainable. The strength was that within the operations mission that they are required to by that Section 330 Public Health Service Act to provide comprehensive care. But the weakness was that they typically FQHCs felt like they lacked the infrastructure such as interoperable electronic medical records or scheduling conflicts to be able to actually integrate oral health with primary care within their facilities. The third major theme was the financing, and this one is one that touched a lot of people and people got very passionate about because any healthcare administrator is going to be looking at the bottom line to make sure that any kind of new program being implemented is financially soluble and can be sustainable. And so the strength that people identified here was that there's actual federal funds allocated to FQHCs to ensure comprehensive primary care. But the weakness being that with the financial sustainability due to payer mix, reimbursement rates, PPS systems, and there's a quote here from one individual who said, if your PPS rate is $350, your scope of services can be pretty large as far as providing dental care. But if your PPS rate is $125 and you provide dental care, you're going to lose money in most cases. And so they were really stuck on this. How do we make this program sustainable under the current environment with funding and given the current prospective payment system and reimbursement rates, etc. And the last was workforce capacity training and scope of practice. And I think this was one that I think Hannah and I both are very passionate about. But the providers themselves, many administrators in these FQHCs felt that the providers working in their organizations had the mission match with their FQHC to really want to provide comprehensive care to their patients. That being said, the biggest weakness is how do we recruit and retain individuals into these various locations around the country that typically are very hard to recruit into. And it does take a special type of provider to work in these underserved communities. So some opportunities there really are to increase the number of dental health profession shortage area designations. And that's not saying that we need to make more. It's just that, for example, in Indiana, we had not done a great job over the past decade in proactively identifying dental shortage areas. And now we've proactively done that, and we've probably have 10 times as many as we did just 3 or 4 years ago because of all the stuff that we've been doing with data infrastructure for the state. And so by getting these dental health profession shortage area designations just applied for and designated will help increase the resources available to recruit and retain dentists and other health professionals in these areas. And then the last thing I wanted to talk about there was the scope of practice. One of the things that these administrators really felt was hindering their ability to implement innovative programs or was the regulatory environment, and they didn't have a lot of leeway to try new things or to use providers in various ways, dental hygienists, for example, or medical assistants, or various other types of staff, flexible use of workers. How can we distribute work to use our workers the most effectively? So that was one that they really felt was hindering their ability to integrate oral health into their system. So as I said here, this is the study citation. The link there it will take you directly to the Journal of Ambulatory Care Management, and it is open access, so anybody can access it, download it. I encourage everybody to dive into it a little bit in more detail, and if you have any questions, please feel free to reach out. I hope I can answer some of them in a little bit, but any other ones that we don't get to today, feel free to shoot me an email or Hannah an email, and we'll be happy to discuss further. I'm going to turn it back over to Hannah. She's going to go through the second study and lead us through some discussion. So thank you guys very much.
Thank you, Connor. So the second study dug into primary care physician roles in health centers with oral health units. This was published in April of this year in the Journal of the American Board of Family Medicine. And in addition to myself and Connor, Dr. Don Weaver with NAC also co-authored with us. And so this study was really built upon and originated from the line of inquiry in the NAC monograph that focused on gathering information and identifying what was going on at health centers around integration. But this question in line of inquiry specifically looked at the primary care physicians, and that could really be primary care providers or clinicians. It could be broadened to include our other primary care providers that are non-physician, that those providers are critical to integration. But unfortunately, as I mentioned in the beginning, we have had this separation where oral health has not really been in their wheelhouse. It has not been incorporated. Oral health competencies have not been incorporated throughout their training, either in medical school, residency, or other health professions, other primary care providers training programs historically. And so the purpose of this study was really to explore the roles of primary care physicians in the oral health integration models of the health centers that were included in the NAC monograph to inform practice moving forward and to identify what were their roles and are these roles that could be translated to other health centers or outside of health centers and to other primary care practice settings across the health system. So study specifics, this design was, it's a qualitative study reviewing key informant interview data and was set up as a comparative case study analysis. The population were healthcare providers that were affiliated with 5 health centers located across the United States, and I'll be sharing how they're distributed and some information on those health centers in just a moment. And so the study methods, key informant interviews were conducted in the spring of 2015 for each of the 5 health centers and included the following perspectives: chief executive officers, chief financial officers, medical directors, dental directors, primary care and dental team members, and then patients as well. So this map is just demonstrating the distribution of the health centers that were included in the study across the United States, and you'll see that they are scattered all the way from the East Coast through the Midwest to the very far west, the Pacific Northwest area. So fairly good representation regionally, with the exception of the South, included in the study. This is actually a table directly from the article that provides descriptive characteristics of the 5 health centers that were included. The health centers varied not only in their geographic location, but in the number of actual clinical sites that they operate. So one little piece of information that some of you may or may not be familiar with is health centers may have, even though it might be like the Bluegrass Community Health Center, for example, which is the first one listed, that doesn't mean that it's one clinical site. Health centers can have multiple clinical sites under the same name. And so you'll notice that the health centers varied in how many sites they operated, how many clinical sites they operated, and whether or not they actually had and provided dental services directly to patients. So of the 5 health centers, only Bluegrass Community Health Center in Kentucky did not provide dental services or have provisions for dental services to their patients as part of their clinical services that they delivered. The size, total patient-wise, varied, as did the patient's poverty level, and also the cost per patient per year reported by each of the health centers. And so these data come from the uniform data system that's reported annually by the health centers to HRSA as part of the health center agreement and their funding requirements. So through the key informant interviews, 3 themes emerged, 3 roles emerged for primary care physicians. The first of these was the role as champion for oral health, and I'm going to go into each of these in greater depth in just a moment. But the champion for oral health means that they actually brought it upon themselves as a primary care physician or primary care provider to initiate or establish an oral health integration program. Member of an interprofessional care team member was also identified as one of the roles of a primary care physician. And in this case, a primary care physician could be a member or the leader of a care team that included dental professionals. And finally, a collaborator with oral health colleagues. And collaboration can look different based on the environment. But in most cases, it includes bidirectional communication and care coordination between primary care and dental care teams. So the champion for oral health, which health center was this role evident? The Bluegrass Community Health Center is located in Kentucky, and the medical director is a family medicine physician who is recognized, actually nationally has been involved in a number of initiatives, but he recognized the need for and took primary responsibility for integrating oral health into the practice and across Bluegrass Community Health Center, and primary responsibility for patients' oral health. Part of the way that this was championed, this physician actually working with leadership at the health center has embedded training, oral health training for all clinical staff members and learners that come to the Bluegrass Community Health Center. So at onboarding, all staff, from the medical assistant up through new physicians that would be hired, and all residents or learners from different programs that come through and are trained at their facility are required to complete Smiles for Life, which is the national oral health curriculum that's publicly available. And I actually have the link to it later in the slides for reference. But all new clinical team members receive this training just as part of their onboarding at the Bluegrass Community Health Center. All of their providers perform oral evaluation. So that's actually a clinical examination of the mouth that includes looking at the dentition and the soft tissue or the gums. They place fluoride varnish, which is a very efficacious treatment to reduce risk for dental caries. And then they have standard patient education and patient messaging. And finally, the referral to the community dentist. I know that Connor had mentioned that one of the issues with health centers, if they don't have a dental program on site, they can set up referrals with dental providers in their community and can pay for those services through voucher. And I will tell you that one of the issues that Bluegrass Community Health Center felt was still outstanding, that there was frustration with the lack of patients that they refer that actually get that definitive dental care treatment that they need. And so I think they at the last that I had spoke with them, were looking at how they could actually expand and provide dental services on site. But very clearly, the Bluegrass Community Health Center had a physician, primary care physician, who was a champion for oral health. He had no dental colleagues co-located with him. He championed oral health integration within his organization. So the collaborator with oral health colleagues. The example from one of these health centers is the Holyoke Health Center, which is located in Massachusetts. And in this example, they actually had bidirectional communication, meaning the physicians and the dentist, or the primary care team and the dental care team, were sharing information back and forth and coordinating in care between primary care and dental care teams. And specifically at the Holyoke Health Center, this was facilitated through interoperable health record system. So they have a technology that is helping them collaborate, that assists their primary care physicians or providers in being collaborative partners with their dental colleagues. Their health record system also has built-in oral health risk assessments into the health history information, and then the information that's gathered through inquiry when patients present for triage. There are oral exams and oral evaluations that are provided. And again, the preventive intervention, the fluoride varnish is placed on the teeth. And specifically at Holyoke, this is placed actually by medical assistants or other clinical staff understanding orders as part of the primary care appointment. They do have oral health education and training that occurs for their primary care providers and their primary care teams in oral health. And this is done through learning sessions with local residencies that they have actually robust dental programs at the Holyoke Health Center. And they also have their medical assistants and clinical medical staff receive specific training with that's affiliated with the Department of Health in Massachusetts, specific on oral health. So in this case, the physicians, the primary care physicians at Holyoke, are collaborators with their oral health colleagues in the care of patients' oral health through information sharing and that constant information sharing back and forth. The member of the interprofessional care team. Two of the health centers had physicians that were working in this type of model or this role. One of them was the Salina Family Health Care Center in Kansas, and the other was the Salud Family Health Center in Colorado. In both of these organizations, they actually have adopted interprofessional, or I would even say multidisciplinary care teams that have incorporated a dental hygienist as a preventive oral health specialist on the primary care team meaning that a dental hygienist actually comes in and is part of the primary care team and provides oral health services to patients that are there for primary care visits. So for example, in a pediatric well child visit, what this may look like is that the dental hygienist would come in either before the well child physical examination or after, and they would actually provide an oral health evaluation, perform a risk assessment, place fluoride varnish or any other preventive interventions that may be appropriate. And then the key to this is that that dental hygienist then acts as a dental care coordinator and facilitates appointments and manages care coordination for patients between primary care and dental care. And so physicians working in these models have an expanded care team that has a member on it that isn't traditionally part of the primary care team, and that in this case is a dental hygienist. There are other organizations, specifically in Colorado, that are working to integrate dental hygienists beyond just preventive services in the primary care setting. So how is this done? Well, it requires that primary care appointment times are adjusted to provide for an extended length for the oral health visit. Also, there's special equipment that can be used. So for example, at the Salina Family Health Care Center in Kansas, they actually had custom carts made, almost similar to crash carts in emergency departments, but they're dental carts that the hygienist actually rolls right into the primary care, either procedure room or patient room, and it has all of the equipment and materials that are needed for the dental or oral health care visit in primary care. So there are some things that are needed to facilitate that. But in these cases, we have physicians working as members of interprofessional care teams. So what are the implications for primary care physicians? Because as I've been sharing information about this, I frequently get asked, well, what about all of the primary care docs that aren't in health centers? What should that look like for us? And so a primary care physician working in a private practice in a rural community, there are numerous ways that they can begin and work towards oral health integration. They can become a champion for oral health if they feel so moved to do so. The first step, of course, would be to, if they feel that they have a gap in knowledge or a gap in competency, to become trained. There are resources that are available through the Society of Teachers of Family Medicine, and that is the Smiles for Life curriculum. I do have the link to that. I would highly recommend that. Our family medicine residency here at Indiana University has incorporated modules from that into residency training in order to prepare our residents to be oral health champions when they get out into practice. Being the champion for oral health in a practice means engaging the entire team and leading the way at making the team see the value of oral health as part of overall patient care for every patient that walks in the door. Being a member of an interprofessional care team is another way. Now, it's important to note that the extent to which primary care physicians can develop and implement interprofessional care teams that include oral health professionals is dependent upon a number of factors. One of those are state practice acts. So you would need to identify whether or not your state would permit you to hire or bring on a dental professional onto your team. Another is how would reimbursements work to sustain the inclusion of a new team member on your team. In the case of the health centers that we discussed, fluoride varnish, the preventive intervention, is actually reimbursable. And so those organizations, actually the reimbursement for the fluoride varnish dental procedure is sufficient to help sustain the dental professional's time and effort on the primary care team. I think that as we move towards an environment that looks at value-based payments, we need to have discussion about some of these basic oral health services are and should be and must be part of standard primary care delivery. And that would also help us move towards this interprofessional team model that addresses oral health in primary care. Finally, the collaborator with oral health. For physicians that may not feel comfortable being a champion right out of the gate, and they may be located in states which currently do not support interprofessional care teams, interprofessional primary care teams that have incorporated oral health, there's still opportunities to become a collaborator with the oral health colleagues that you have in your community. And that can include reaching out to the dentists in your community, not just to identify referrals, but to actually discuss and establish protocols for care coordination and that bidirectional communication. Obviously, if we're talking about private practices for primary care and private practices for dentistry, the likelihood of us getting in rural communities to interoperable health records within the next few years is probably not likely. Hopefully someday we'll get there, but that doesn't mean that there can't be other processes put in place to ensure that we can have enhanced care coordination and dialogue and bidirectional communication between primary care physicians and oral health colleagues. This is a list of resources. I could have provided probably 5 or 6 slides full of resources. I am happy for anyone that's interested offline to reach out with any questions that you might have. I can direct you to the true experts in this arena if you're interested in integration. The few that I've provided here, I told you health centers at the national level, there's a lot of work that's been done. Great work out of Qualis Health and their Safety Net Medical Home Initiative around oral health integration, kind of a roadmap framework for integration within the medical home model. If you are a health center or you're affiliated with one, I would highly recommend that you check out those resources. If you are a primary care or medical provider or professional and you'd like to find out more about oral health, please check out the Smiles for Life National Oral Health Curriculum. This is a free resource that is publicly available, and as many healthcare professionals as possible need to have access to and become familiar with this information. I'd like to thank you so much for your time today, and I think, Christy, we're going to go ahead and open it up for questions.
Great, yes, thank you so much, Hannah and Connor. Let me see if I can get our audio fixed here. I think we're good now. Yeah, we are going to take some questions, as many as we can get to in the next 11 minutes or so. So if you will go ahead and go to the questions area of the toolbar for the GoToWebinar control panel area and enter those questions in there. We'll take as many as we can. First, I want to start off with this one for you, Hannah. So what are some tangible ways that primary care settings outside of health centers can begin to integrate oral health?
Thanks for that question, Christy. Primary care settings outside of community health centers. So I would say that the first thing they need to do is look at how can you operationalize or incorporate some of these higher level oral health competencies into your practice, whether that's a leadership like a executive, a health administrator, or a physician or medical director. So for example, for oral health risk assessments, primary care settings, primary care offices, they're doing risk assessments for diabetes and a lot of other conditions. And some of that information is gathered through health history questions. So it could be as simple as ensuring or developing and embedding oral health, targeted oral health questions into the health history. So for example, you may be asking questions about diet to assess risk for diabetes. But is there a way to ask targeted questions that could get to sugar consumption and risk for dental caries, for example? That would be the first thing that an office could do, is incorporate risk assessment, oral health risk assessment, into the overall risk assessment for patients.
Okay, great. Um, what is needed to bring a dental professional onto the primary care team?
Yeah, and I touched on this a little bit when I was talking about the interprofessional care team models. There are a number of things that have to be in place. First, the state that a practice is located in needs to have provisions that enable a dental hygienist to either work autonomously or work under the supervision of a physician. So we do have a number of states currently that have such provisions, and we do have hygienists that are working in those models. But that is kind of the first sweep. Now, that would be if you want to fully leverage that professional. It has to be permittable and allowable under state practice acts. Second, preventive interventions, actually all 50 states now provide for fluoride reimbursement, I believe, to primary care providers for children through their Medicaid programs. And so that is a way of possibly funding and sustaining, like the health centers are doing, a dental professional on the primary care team. But I guess you don't have to have a dental professional on your team to be doing that. Preventive interventions like fluoride varnish can actually be delivered by a primary care provider or by clinical staff under standing orders. They're fairly simple. So I would say the first sweep is, what does your state policy environment look like? And does it support these interprofessional or interdisciplinary practice models? If so, for your organization, what would need to change? What are those things that you would have to do? And what would your financial model be to expand and bring on a new care team member and to sustain that care team member?
Great. This is a good follow-up question to that. What scope of practice issues for dental auxiliaries would you consider obstacles to interprofessional practice?
So I would like to ask a clarifying question. So a dental auxiliary, are we saying dental assistant, or are we grouping dental hygienists and dental assistants under auxiliary?
I'm not quite sure. I think this person can come back and clarify. He says all of the above.
Okay, so the specific practice acts would be the supervision requirements. So here's an example. Currently in the state of Indiana, and Connor's study that we did here with our health center executives to find out barriers, it was identified that the supervision requirement for dental hygienists was a significant obstacle to the adoption of multidisciplinary primary care teams that included oral health. Our supervision requirements in the state of Indiana specify that a dentist has to be engaged in the supervision of a dental hygienist. It's not direct any longer. Those provisions now allow for a time period where once a dentist has performed an exam, a hygienist then may provide treatment and engage in patient care. But that still requires a dentist supervise and see the patient and evaluate the patient prior to the delivery of any dental hygiene services. That is different in our state from other states. So for example, in Colorado, there are no such supervision requirements for dental hygiene. And so if we look nationally where these innovative models are being the kind of the incubator for these innovations, it really is the states that have no such supervision requirements. And in those states, they actually are able to leverage the workforce in these new ways and in these new models. So if you're located in a state, the first thing you would want to do is understand the supervision requirements and the supervision provisions in your practice acts for your dental auxiliaries and specifically dental hygienists, but it could in your state also be dental assistants.
Great, thank you. How can you identify and develop collaboration with dental professionals to support oral health of your patients?
That's a great question. First, you have to identify dental professionals. So you may have colleagues or friends that you may know from community related activities you're involved in. There may be, if you are a primary care provider or a primary care office administrator or health administrator, and you are having a difficult time identifying dentists in your community, you can always go to the dental association within your state or the component within your community or locale and initiate a conversation that way to identify potential collaborators in your community. And then once you've identified them, be very purposeful about setting up discussions and relationships. When I was out actually in clinical practice as a hygienist, frequently the dentists that I work with would have lunch and learn sessions or lunch meetings with other dentists or dental specialists to talk about care management, case management, management of patients and conditions. This is no different. This is just crossing the border and really crossing that chasm from medical and dental and developing discussions, collaborations, and communications now with people not just in dental, but or just primary care to other medical specialists, but we're talking about doing it across disciplines. So if you can't already and you haven't already identified dental professionals in your community to establish relationships with and collaborate with, contact your state dental association. They'll let you know if there's a component association in your region, in your county. You can reach out to them and initiate conversations that way. There's also opportunities for the different associations for the professions to begin dialoguing with each other at a state level as well.
Great, thank you so much, Hannah. I think that brings us almost up here to our hour. Peter, if you'd like to say any final thoughts?
Yeah, I want to say thank you to Connor and to Hannah. And Hannah and Connor, real quickly, do you have any sense of whether or not the accountable care organizations throughout the country are adopting the some of the practices that you're talking about, and particularly using more of the non-dentist care workforce?
So, Peter, I think that that's been explored, but not as widely as I think it could be. I think that there is a lot of opportunity for work to be done in that area, specifically through accountable care organizations.
Yeah, okay, well, maybe next time.
Yes, maybe next time.
Okay, great. Well, thank you both. Christy, Thank you
so much.
I'll let you bring us to an end, Christy. Thank you.
Perfect. Yes, and so that will conclude our webinar today. Thank you so much again, and thank you for all of you who attended. Again, we are recording, so we'll have this posted to our website. If you know someone who wasn't able to attend today, please direct them to our website, healthworkforcestudies.com, and they can watch here later after the fact. Save the date for our next webinar in this fall series. This one will focus on the integration of behavioral health into primary care on November 28th at 2 p.m. Eastern Standard Time, and we'll be sending out some communications here shortly about that with registration. So thank you all very much. Have a wonderful day.
Thank you.